Welcome everyone to our Driving Quality Improvement in Cancer Services through Learning Event Analysis webinar. I'm Zara Gross and I'm the Early Diagnosis Lead in South East London Cancer Alliance, and I'm joined by two of our presenters, so Dr. Anthony Cunliffe, who is Joint Clinical Chair of the Alliance and Joint National Lead Macmillan GP Advisor and Macmillan GP Advisor for London, and also Dr. Winnie Kwan, GP Cancer Lead in Bexley and Education Lead for the Alliance. So I'm just going to go through some housekeeping rules and information around the evaluation form. So just to let you all know, you are on mute and your cameras are turned off by default, just to ensure we've got clear communications and privacy throughout the webinar. If you have any questions, please click the Q&A button, which is on the bottom of this window. And if you'd like to discuss anything with video and audio, please indicate this when you ask your question. We'll cover questions either during the relevant presentation or after either Winnie or Anthony have spoken. And if you have any technical issues, then let us know via the Q&A button as well, or via email. And the presentation will be recorded. We are also going to be asking attendees to just complete a poll. So we will have one after around slide 5 and then one at the end, and we just ask you to complete that when it pops up on screen. And with regards to the certificate of attendance, so you'll receive a link with an evaluation form, and we ask you to complete that, and then after you've submitted that, you'll receive an online evaluation form confirming your attendance at this webinar, and you can download that and save that. So I'm just now going to hand over to Anthony, who's going to take us through what is an SEA-LEA.
Hi everyone, thanks for joining today. We're going to talk a little bit about the theory of a learning event analysis, and then move on to what makes a good quality learning event analysis, and then I'm going to hand over to Winnie, who's going to go through some case reviews, to some examples to bring it to life a little bit. So do you want to go on to the next slide, Zara? Thank you. So we'll just look at a couple of definitions of learning event analysis or significant event analysis first. And it's important because, we all, these should be bread and butter for us in general practice really, but there has been a lot of confusion over the last few years about what should be considered a significant event and what would be a case review or a learning event. And things changed as far as the appraisal process is concerned with that. So we just kind of wanted to get that clear initially. So the MPSA actually talks about a significant event as a process in which individual episodes, either positive or negative, are analysed in a systematic way to establish what could be learned about the overall quality of care and to indicate any changes that might lead to future improvement. And I think this is a really good example of what a learning event analysis is really. I think it's one of the better definitions really. The GMC refers to serious incidents, and it describes these as events where there was or could have been a detrimental outcome involving patient safety. And then the RCGP had previous definitions of significant event, and this kind of entailed all the events, and GPs were getting a little bit confused about what they should be including in their appraisal process and what they should be including as a significant event or a case review. And so the RCGP made a discrimination between significant event and learning event. So an SEA really is any unintended or unexpected event which could or did lead to harm patients. This could include incidents which didn't cause harm, but could have done and could have been prevented. So really, these are more like your critical incidents that we now would include in our significant event section of our appraisal process, rather than the learning events. So primary care significant event analysis or learning event analysis in primary care, which is a form of quality improvement activity, that's the real crux here, and may involve events that are routine in practice, but worthy of analysis to see what could have been learned or improved. Or I would definitely say, good events can be, positive events can be included as learning event analysis too, if there's a real purpose to disseminate learning and perpetuate improvement. So, most of us do these events when things potentially have gone wrong, but it is okay to do them when things have gone very well as well. So why should we do learning event analysis for cancer diagnoses? So the cancer pathway can be a long pathway and a complex pathway. So there are multiple steps when problems can occur. We know that late diagnosis in the UK is unfortunately still a major problem, and performing a good quality learning event analysis or SEA on missed or delayed diagnoses can be really helpful to try and make sure that improvements can be made so that the same problems don't happen again. Emergency presentations also still very common in the UK, and sometimes, sometimes there's nothing that can be avoided, but sometimes doing a learning event analysis or a really good quality case review on people that have presented first to the emergency room with and being diagnosed with cancer, by looking back through and doing a good quality analysis on their notes, we can perhaps identify why that may have happened and why the cancer was diagnosed earlier. And also, it's not just about cancer diagnoses, really. So it's also about anything that can go wrong in a patient's pathway. So points of transitions of care. So after finishing acute treatment, potentially, we do see that patients fall through the net here and things can go wrong. And learning event analysis can also help in those situations as well. We've seen certainly some significant impact of the COVID-19 pandemic on early diagnosis of cancer. We've seen, various delays in investigations and treatment, often absolutely necessary. But we've also will have seen changes that have happened because of the changes in the pathways, where perhaps things haven't been managed as well as they could have done. So perhaps more than ever, LEAs are going to be important over the next 6-12 months. And very importantly, the Primary Care Network DES and the QOF QI for this year specifies that a learning event analysis, significant event analysis, should be done as part of the DES and the QOF QI. We had a separate webinar on the QOF QI where we specified the differences and what the QOF and the DES ask you to do LEAs on, but essentially it is asking patients to do quality improvement activity focused around significant event analysis to try and learn and drive improvement. And as I say, we all have to do this as part of the appraisal process. We all have to do this as practice as part of CQC. So understanding when it might be useful for cancer diagnosis can be helpful. So what makes a good quality learning event analysis? So, some of this might seem a little bit obvious, but unfortunately, as an appraiser, we often see learning event analysis that are done quite briefly and don't necessarily always have the right details in. And unless they're done robustly, they are never going to lead to that change for the future and the improved care for other people. So it is really good to reflect on what makes a good quality one. And Winnie will talk a little bit more about this later, but there should be very clear and robust details. Really importantly, and we'll talk about it a little bit more, there should be good evidence of reflection, because reflecting on how well things went is what helps us identify where things could have gone better, and then focus on how we can make sure that things go better in the future. So really, through transparent reflection is really important. We should ideally choose events in which we as the individual were directly involved, and that's particularly for appraisal purposes. That as an appraisee, it's not that helpful to bring, unless it was a significant event perhaps that involved the practice. For those case reviews, really it should be a case that we were directly involved with. There should always be areas for improvement identified, or if it was a positive event, a clear explanation of how that learning has been disseminated. We should ideally involve all relevant parties. Now, a lot of the time this means involving secondary care. Now, it can be a real challenge, but if we're doing a learning event analysis or a significant event analysis on a case and problems are identified that involve secondary care, we really should be involving them in that process or sharing the LEA with them. Otherwise, it's going to be a challenge to really drive the changes that are needed to improve care for the future. As we've already said, there should be evidence of implementation of change where that's appropriate, which should be in most cases, even if those changes are small, or even if those changes just apply to ourselves. And we should be disseminating the learning. So these should be involved when relevant in a practice meeting, so that the rest of the practice can learn can share that learning. So we should always involve the specific dates and times, and these may be multiple dates and times, but it's really important to involve them in the description of what happened, because that's how you're going to be able to reflect on where things potentially went wrong. There should be a clear description of the events, and it needs to be thorough. So it shouldn't be a high level description of what happened. It should be detailed and involve where, why, or how the patient presented, how many times, what actions were taken at each presentation if it was multiple, what follow-up was planned at each presentation if it was multiple. And even though it needs to be very detailed, a patient should not be able to be identified. So it shouldn't be considered patient identifiable data, because it is going to be shared with your appraiser if you're including it in your appraisal. Sometimes it's shared, across practices, or there's across PCNs. So we should make sure that the patient isn't identifiable. Sometimes that can be tricky if it's an unusual diagnosis potentially, or very specific things went wrong, and so you just have to review it at the end and make sure that it's not identifiable and it can be shared. Otherwise, it can still be useful for your own learning, but it perhaps shouldn't go further than that. And we've already said there should be really clear evidence of reflection. So what went well? Really important to start with that. What could have been done differently or could have been done better? Reflecting on whether it reveals a knowledge, skill, or performance issue, either for you as an individual carrying out the LEA or for somebody else involved. Was there a significant safety quality concern? And if there was, should that be raised in a different way? Does it reveal a pathway problem or a gap in services? And if so, how can that lead to change? Who do we need to share it with within the CCG, within the ICS, within the Alliance, or whatever it might be, to try and drive changes in services? What changes are necessary to make sure that similar events don't happen again? And that's a real important part of any LEA where it's appropriate. And was it relevant to you as an individual carrying out the LEA? Was it a team problem, and does it need team change or organizational change? And if so, we need to involve all the relevant parties. Structure and analysis. So there are templates out there that have been developed for significant event analysis and learning event analysis. Macmillan Cancer Support partnered with the Royal College of General Practitioners to develop an SEA toolkit. And if you Google SEA toolkit, that will bring you Macmillan RCGP SEA toolkit. It'll bring you to all the resources that are available on the RCGP website. They're still all titled significant event analysis because they've not been changed yet. That doesn't really matter for purposes of appraisal or within the practice, or you can just take the templates and use the guidance that the templates include and complete it using another way. And the templates are really good though, because they can act as prompts to make you consider all the different elements we've just talked about and consider things that you may not have thought of previously. And they certainly promote robust reflection, and that's a really important element of any analysis. And they also encourage taking the SEA forward, bring about real change. So the template specifically asks, what actions have been taken to bring about change. And it does encourage involvement of the patient family. Secondary care, I think, is more often appropriate, but it can be relevant sometimes to involve the patient or family in discussing a significant event or a learning event. Now, that's challenging, absolutely, and should only be done if we really think it's integral to making the relevant changes. But that's just a pictorial element of the toolkit, of the template you can find on the toolkit. And it includes all these questions. So what happened? Why did it happen? What's been learned? What's been changed? What's the potential impact on the people involved? And what was effective? And that's the last question. What was effective about this particular significant event analysis? Winnie's going to talk more about that now.
So hello everyone. I'm sharing with you a couple of examples of learning events that were real, and they were submitted to a Macmillan sponsored workshop some 2 years ago. The dates, gender, ages of the patients have been changed, and that the consent has been obtained from the practices. So I have selected cases which were really relatively straightforward for the sake of time, but we can still illustrate where the reflection can be improved. So this is the first example of an 8-year-old girl who presented to the practice with back pain and a limp after a holiday in Portugal. So the history is very brief. So what happened as it is presented there, and the author of the LEA noted that the patient was pale, distressed, and looked unwell, and spoke to GP1 for advice, and she was told to make an urgent referral to local peds by phone, and the patient was admitted, and the diagnosis was acute lymphoblastic leukemia, and the treatment started. Note the fact that there was a discussion with GP1, and I suspect this learning event analysis was completed by a nurse practitioner. So it was straightforward, so fair enough, with a very brief account of what happened. And this is also to demonstrate that it can be, LEA can be done on a positive event. And certainly a childhood cancer diagnosis, people will want to share it with their practice because it doesn't happen that often, hopefully. So second question, why did it happen? So the author said that we feel that the patient was referred rapidly and appropriately. So I think fair enough, the author was quite rightly pleased with the prompt action that was taken, which led to a cancer diagnosis, but did not exactly elaborate on the analysis of the presenting symptoms and the decision-making process that led to the immediate referral. And I think that is probably quite crucial for learning purposes. Yeah, maybe for a trainee or less experienced doctor in the practice. So it could have been there could have been more details with the thinking process. So the third question, and next slide please, Zara. What has been learned? So reiterated red flag symptoms in children. So I mean that is certainly quite brief, yeah. It was just a phrase. So more details could have been included. For instance, who did the reiteration? I mean, was there a practice discussion of some or all of the red flags of childhood cancers? Was there a presentation on acute leukemia in children? And has the learning been extended to the non-clinical staff? Yeah, because it was quite crucial that the receptionist fitted this little girl in promptly, and maybe they would like to know that actually this is what happened, and that it would make sense to them how to triage perfect, as perfect as possible. So what has been changed? And the author put down no changes have been made. So I was a little bit surprised because there could have been a possible discussion around maybe access to children presenting with red flag symptoms, maybe a referral pathway for suspected cancer in children, maybe that needed to be clarified for everybody involved, and flagging up the diagnosis in the record perhaps of this little girl's ALL. And what about the safety netting process in the practice? Or is there any protocol that can reinforce the consistency of good practice, given that this was a positive event? So anything that can help to even strengthen the management in the practice, that would have been part of the reflection. So what was the impact of those involved? That's the next question. So the author put down that the family were very grateful for the rapid referral and diagnosis. I mean, without a doubt, I'm sure that was the case. But what about the impact of a child with leukemia on the family? What about the impact on the clinician and the practice? So was there any improvement in the confidence in dealing with childhood cancers? So the clinician did consult the GP prior to making the referral. So maybe that, whether she felt that, her concern were validated, and that, maybe that would help her for further learning in future presentation of vague symptoms. Any plan to enhance knowledge of childhood cancers, for instance? So has there been a strengthening of the relationship between the family and the practice because of this positive outcome? And would the practice, for instance, consider contacting the parents to offer further support or make access easier for to the GP in the future for this little girl? So there are lots of things that could have been reflected upon. So the last question, what was effective about this SEA? So the author put down, we discussed this case at a 1.5 hour clinical meeting regarding cancer SEAs. So, but there were no details about this meeting. So who were the people present? Were there just the usual doctors? You know, did they involve any locum or any learners? Was there any consideration of sharing the learning with absentees? And has the doing of the SEA been valuable to the clinician in this instance? So was there any even possible plan to invite a pediatrician to talk about childhood cancers, perhaps in a learning event? So there are all sorts of things that might have been triggered by this particular event, and I was just trying to show you maybe some reflections that could have been included. So let's move on to the next example, Zara, please. And next slide. So the next example is about a 50-year-old patient presenting with symptoms that turned out to be lung cancer. And so what happened was that, she presented with a cough of about 2 or 3 months history. There was possible fever in the history. She was a smoker, no weight loss, but there was appetite loss, no past medical history of note. So it caused some concern, obviously, because the GP then sent her on to have chest X-ray, sputum analysis, and spirometry. And despite the physical examination, that the chest was clear. So 4 days later, the chest X-ray came back with suspected left upper lobe consolidation, treatment, and then referral if persistence. I'm sure we are all pretty familiar with this sort of report. Yeah. So the practice then sent a letter to the patient to make sure that the patient would book an appointment. In the meantime, the receptionist 6 days later, noted that no appointment had been booked yet, so sent another letter. So, but in the meantime, in fact, the patient actually called the surgery to make the appointment with the nurse. Next slide, please. So nurse 1 did the spirometry, which was normal, and discussed with the GP2, who advised patient about the chest X-ray findings and treated her for the infection that was suspected. And actually, the GP directly booked a follow-up appointment for the following week and advised that she would need further repeat X-ray and a follow-up review in a month. So the patient wasn't getting any better, no improvement with the antibiotics, and so came back to see the GP again in after over a week. So the second GP suspected that maybe urgent referral as a suspected cancer might have been indicated. The blood test actually showed up that there was a leukocytosis, white count of 20, with a neutrophilia pattern, and the platelets was raised. Then the inflammatory indices were also raised, and notably calcium was raised to 3.02. So 4 days later, the patient was contacted by the GP2, and the referral was made to hematology. Now, the patient was seen within 10 days at hematology and was admitted by A&E from clinic. And then on investigation with CT, it showed up a lung mass with left hilar lymphadenopathy. So the diagnosis was actually squamous cell lung cancer, T4N2M0, grade 2. Next slide, please, Zara. Thank you. So what happened there? I mean, there was clear documentation of timeline of events with some relevant investigation results. The patient was presenting with respiratory symptoms, was found to have abnormal investigation results. And then the clinician made a 2-week wait referral, but to the wrong specialty. Now, I'm sure this is a problem that many of us have faced in the past. So but when the question was asked, why did it happen? The author analyzed what were the positive factors about this, this chain of event, and felt that it was identified at the initial consultation that this patient needed urgent referral and urgent investigations, and the abnormal result was followed up, and there was safety netting done at reception because she was not noted to have booked a follow-up appointment, and the patient was referred via 2-week wait to the cancer services on the receipt of bloods. But the negatives identified by the author was that although the results came in on the 15th via out-of-hours alert, I think the doctor who was with whom the patient was registered was not in, and that the results were actually actioned some 3 days later. The hypercalcemia, the patient thought that, the practice thought that it was definitely abnormal, and that it had to be there had to be some serious pathology. And however, for some reason, they could not decide between respiratory or hematology and chose hematology. So next slide, please. Sarah, thank you. So what has been learned? So the learning point, they put down that abnormal results, the system should alert this to the duty doctor. And the calcium level was not a level to necessitate immediate attention, but care needs to be taken when reviewing results. I think obviously the practice was worried that the calcium was so raised, but they kind of tried to reason with themselves that actually perhaps no harm done, because that the patient was not immediately admitted on the basis of the calcium level. The second learning point was about there was no clear best department to refer at the time. So the fact that this patient was presented with respiratory symptoms, and that there was an abnormal chest X-ray, and there was thrombocytosis. So I think maybe that at the time the clinician was not aware of the association of thrombocytosis to lung cancer. I mean, now we have been alerted that legacy with thrombocytosis association with lung cancer, esophageal, endometrial and gastroesophageal cancer, and colorectal cancers. But perhaps at the time they were not aware of this association. So what has been changed? So they put down increased awareness about keeping cancer referral guidelines in mind and sharing dilemma in referral letter. So again, it may be that there was that the consideration of the differential diagnosis might have been explored, such that to explain to themselves why hematology was chosen. Was it because they suspected it was myeloma? But the cognitive process was not revisited, if you like, and because that is possibly where the learning could have taken place. What has been changed? Oh yeah, so we've discussed that, and then the so has the practice made any efforts in maybe increasing awareness of keeping cancer referral guidelines in mind? Was there a particular clinician nominated to take the lead on this? And has there been any consideration of maybe using clinical decision support? Because all these could help to make the correct choice of referrals. Now, the next slide, please, Zara.
I have a question. Let me just get that up because it might be. Oh no, that's fine. Someone's just said that they've had to leave. Sorry.
No worry. So the next slide, please. So what so what was the impact or the potential impact on those involved? So the author put down little would have changed for patient or carer or GP. So it does sound as if the person doing the LEA was not the GP involved. As Anthony said earlier, that it would have made more sense that the person involved did the analysis. But so in order to explore what the impact would have been on the patient or carer, I think the cancer care review would have been indicated. And but obviously the timing of when one wanted to do the cancer care review depend on the choice of the patient and the choice of the practice. So therefore, it might have been that the impact could have been explored later, and whether there was any feedback from secondary care regarding the impact of the patient or the carer, because they might have given more details on exactly what happened since the patient had been referred. Was there any impact on the clinician or the practice? And how did the clinician feel about adhering to the advice of the chest X-ray report, as it then turned out to be a cancer? Was there any agreement on the decision amongst the clinicians? So there are all sorts of questions that might have been explored in order to make to get some learning out of this case. So the last question was, what was about this SCA? So it says, the reply was that they highlighted our safety netting processes were good in terms of ensuring patient reattended for follow-up for her investigations, and discussion highlighted cancer referral guidelines. So again, maybe we could dwell into it a little bit more. Was there actually a practice discussion, and who attended? Was there admin staff involved, as they are quite crucial in the safety netting process? So was there an electronic safety netting system in the practice that might have given the practice confidence that there is consistent safety netting? And was there any plan for any education session regarding cancer referral guidelines? Because they're not easy to learn or to remember, and maybe that people might want some desktop resources from Macmillan or Cancer Research UK to help them to refer to the cancer referral guidance. So there are lots of things that could have been included in this in the reflection of the cases, despite the fact that the cases themselves were quite simple and straightforward. So I hope the above exercise have been of use to you, and that help you to think about what could have been included in the reflection in the future. So on this note, we might want to run the next poll, please, Sarah.
So thanks for filling that in, and Winnie, thanks for those examples. I think they were really great examples, and some reflections for me would be the first one. Obviously, it was it was a positive event, so there was no delays. Obviously, none of us come across that many new childhood cancers, and so to get it diagnosed so quickly was really important. I think from a learning event analysis point of view, though, there either perhaps wasn't very much to learn, and therefore, I'm not sure it's an appropriate case for an example, or if you're going to go to the effort of carrying out an LEA on a case like that, then as you said, you've got to really think about, well, what do we need to do? How do we make this a quality improvement activity? Because as it was just sharing of a brief event. So I think to make it a quality improvement activity, you have to involve some education with it as well. I agree with what you said. And then the second example was interesting to me in that it was good quality in that a lot of the details were there, and they'd really put an effort into going through the timeline and including all the relevant details. And it almost felt like they ran out of steam a little bit when they got to the end of the LEA, looking at really what had been learned. And I think often, especially if you're doing the case and it wasn't you that was mainly involved, And it's really hard to try and point out negative things where you think things could have gone better. But obviously, if you're going to go to the effort of carrying out a learning event analysis, then you really have to drive right through to the end. Otherwise, it's just recollection of event and not a quality improvement activity. So I think there were clearly things that could have been discussed there, things that could have gone differently, and more learning that could have happened as a team, as you say. Who was involved in that, who was involved in the discussion. So I think it was a better example, and a good example of a great case for a learning event analysis, but also highlighting that you really have to go all the way through that process, use the template, and really put as much effort into each of those sections of that template to really highlight where things could go better next time. So thank you for that, Winnie. I'm not sure if we have any questions. I'm just checking the chat. No, they're just the poll results. So I think in the absence of any questions, we can probably leave it there. I know Zara was, I don't know if Zara's still on. She would definitely be wrapping up and explaining how you carry out your evaluation of today. Zara, are you there?
Can you hear me?
Now, yeah.
Yeah, okay, great. I'm going to keep my video off. So just to ask you guys to complete the evaluation form. There will be a link at the end of this webinar. So there'll be a link on Zoom, and we'll also share that link through Eventbrite as well. So just please complete that, and then an evaluation, a certificate of attendance will be, and then you can download that. So yeah, thank you both for presenting and for this session, and we'll share the slides as well with you all. And if you'd like any further information, then please do get in touch with us. I'll share my email address with you all. So thanks so much, and have a lovely rest of the day.